My name is Nestor Gonzalez. I'm professor of neurosurgery at Cedars-Sinai in Los Angeles, and I have the privilege of serving as one of the co-vice chairs for the Acute Ischemic Stroke Guidelines 2026.
Hi, I'm Heather Fullerton. I'm a pediatric vascular neurologist and professor of neurology at the University of California, San Francisco, and also president of the International Pediatric Stroke Organization.
It is a pleasure to have this opportunity to discuss one of the most interesting advances and new topics that is being discussed in the Acute Ischemic Stroke Guidelines. That is the treatment of pediatric patients with acute ischemic stroke. This is the first time that the guidelines of the American Heart Association recognize and provide some guidance for the management of this important population. As we all know, stroke may affect patients of all ages. However, historically, pediatric patients have been underdiagnosed or not recognized when they are suffering symptoms of ischemic stroke. Even when they are, there is sometimes the misconception that strokes will affect them less and that they will not have very serious consequences as the adults do. What is your opinion regarding that, Heather?
As someone who takes care of these children that have survived strokes, I am absolutely of the opinion that their stroke should be treated acutely and that we should do as much as we can to minimize the severity of their infarcts, because these children can go on to have really significant lifelong consequences, and not just in terms of physical disabilities that limit their participation in sports, for example, also cognitive impairment that can limit their ability to function in school, but a big emotional burden as well on both the child and their family. And this often really limits their ability to return to their communities. Often these children are uncomfortable going back to school, end up being homeschooled. So the consequences of an ischemic stroke in a child are tremendous. And so they might seem to have better recovery at times than an adult, but it doesn't mean that they're not being negatively impacted in a major way and in a way that affects them for their lifetime.
Yes, I think that recognition was one of the most important motivations to include these recommendations. The second motivation came from the evolution of the treatment of stroke. In the last decade, we have developed techniques that have changed completely the way we treat patients with acute ischemic stroke. However, pediatric patients have not been included in many of these studies. And there are some basis for the recommendations that the guidelines have, fundamentally from groups of individuals with experience in pediatrics that have tried to extrapolate the treatment for ischemic stroke from the adults to the pediatric populations. The guidelines include some recommendations based on that evidence to treat patients with endovascular techniques. And those endovascular techniques can be available for many of them. However, pediatric populations are special. What is your take in this impact of the recommendations to potentially offer endovascular therapies for pediatric patients with a stroke?
I would say that the pediatric stroke community is absolutely delighted that children have been included in these guidelines, because we think that this will be the beginning of the end of a lot of tragic stories that we deal with on a day-to-day basis, where children are potentially identified as having a large vessel occlusion, and the providers that are taking care of them in that emergent setting do not know how to respond. They've lacked guidelines, they don't have pediatric stroke workflows, and they scramble. And it's really devastating, not just to the patient, but also to the providers who, after dealing with a child with a large vessel occlusion, feel really badly that they weren't prepared. And so this is now a call to action, I feel like, for both primary and comprehensive stroke centers to really get prepared to deal with children with stroke and give children access to these therapies and interventions that have proven to be so effective in adults.
Yes, I agree completely with that. And I think this is the beginning of a lot of work that still needs to be done. For some of the colleagues that are seeing this message, they also may feel the pressure of, wow, now what I'm going to do if I see a patient with a stroke. We have recommendations that guide to some extent some of that treatment, but this goes way beyond that. What kind of advice can we give our colleagues? If you are in an institution where you potentially can detect a stroke, what kind of steps you need to do to be prepared?
Yes, that's such a great question. We have worked with the American Heart Association to develop a pediatric stroke pathway that I think will provide some guidance to sites that are trying to become prepared. We also actually have resources on the website for the International Pediatric Stroke Organization checklists to make sure that you are ready for a pediatric stroke. It really starts first with awareness that strokes even happen in children, that children need emergent imaging to try to identify a stroke, especially a stroke with a large vessel occlusion. Making sure that imaging pathways are in place. Do you have access to MRI scans for emergent imaging in children because children have high rates of stroke mimics? And then, if you identify that stroke, especially a stroke with a large vessel occlusion, do you have the resources at your institution to take care of that stroke? Or do you need to partner with another institution in your region that has that pediatric stroke expertise and can take care of that child? And a lot of these decisions are really going to be very individual, institution by institution, depending on how institutions are set up, whether they have pediatric facilities within their health system, whether they need to work with a pediatric facility outside of their particular hospital system. These things really need to be figured out in advance because we see different models of neurointerventionists coming to children's hospitals to treat children there versus children being transported with pediatric providers like pediatric anesthesiologists to a comprehensive stroke center to get treatment and then get transferred back to a children's hospital. So there are many different models. The pediatric stroke community is really excited to work with people to help each institution develop their own pathway and feel confident that they're ready for a child with a stroke.
Yes, I think that's a very important message because it is true that a stroke is not that common in kids. That is not a reason to think that it cannot occur. We need to be aware that pediatric patients can have strokes. And I think the most important part is to be ready. And that readiness may include exactly that, accommodate your resources with the resources of your city or your town, with colleagues that may have more experience to do this and work together. The care of pediatric patients with stroke goes beyond what the recommendations are stating. And it's not only endovascular care, requires intensive care, early recognitions, emergency care, and all those things require that we all are prepared. I think these guidelines are a call to action, as you well put, to be ready. And that includes to be ready to react and to act in the benefit of pediatric patients that may be suffering acute ischemic stroke. Any final thoughts about this?
I would say that it's worth remembering that the etiologies of stroke in children are different, and that has led to certain concerns about applying some of these acute therapies to children. For the most part, we have found with the different observational studies in children that it's okay to proceed. If you see a large vessel occlusion in a child, especially an older child, it's generally okay to proceed. There are certain etiologies like focal cerebral arteriopathy, a cause of childhood stroke, where endovascular therapy might not work as well. And in some anecdotal experience, when those children had their clots removed, the clots are more likely to reform. But we generally would encourage everyone to be prepared to treat these children, recognize that the etiologies are different, but still proceed with consideration of treatment of an acute stroke. For the younger children, really connect with pediatric neurologists, get their input, but then try to set up a pathway for these children that allows them to proceed. And then we'll do a lot of the etiologic workup afterwards. So we don't want that to be the barrier to moving forward with treatment of these children.
I think also the call will have to include the need to do more research, to advance the field, to verify that these techniques that we use in adults are applicable broadly in pediatric patients, and if not, to develop the techniques and the approaches that are necessary. Well, it has been really a pleasure, and thank you very much for all your hard work in the pediatric community to bring this to the upfront line of the neurology's minds. And we hope that the guidelines constitute that stepping stone where many things will be built for the benefit of these patients. Thank you, Heather.
Thank you.